Okay, so we're nearing the end. Can you believe it, huh? So I think I got this right according to the final exam schedule. Our final exam will be Friday. The only difference is that unfortunately I couldn't get in a computer lab, so we're going to have to take it on paper in this classroom on that date. I will give you guys Scantrons. Don't worry about bringing them, right? And I'll even have number 2 pencils in case you forget to bring one, okay, and erasers. So I'll set you guys up since I couldn't set us up the way I would like. And so you'll see that it's not available to you just yet, but I'm building and putting together, I'm going to put it all together in one section, one folder for Unit 4. So I'll have the objectives, the PowerPoints, and the homework links all up in there. And so one thing that I forgot to do last time, because we did finish skin, is I forgot to put the homework link for you guys. So it is in today's folder. And so we're on our last topic for Unit 3, which is respiratory today. What else did I want to say? Don't forget to work on the discussion board for this unit. You get to pick your own infectious disease, anyone covered in your book. And if you're just using your book, you just write the page numbers for your citation. You don't have to do MLA unless you are citing someplace other than your book, right? So that I know where you got the information in case you have misinformation, which hopefully isn't the case. And then this set of Connect assignments. So notice that there are, I think, 4 assignments in here. Some of them are kind of lengthy. I apologize for that. This is material that you're not going to be tested on, but it needs to be completed by the last day of classes, which is April 4th. That's why there's that deadline, okay? May 4th. What did I say, April? Yeah, I'm in April, so I'm saying April. Okay, so make sure that you're working on those, right, and get them done by that date. And it's just basically to make sure you've reviewed these topics, okay? Just evidence that you've been assessed on them, even though we're not going to lecture or test on them. I lecture a little bit, right, related to some of these topics as we go through each one of the diseases. And we will talk a little bit about HIV and the last one, which is blood and lymphatic. So moving on to today's lecture, I had updated some epidemiology for the skin lecture, and I've done the same for today's lecture. So you'll notice that in Friday's folder, let me go back down to it, I put a link and it says updated skin infection PowerPoint. And the only thing that really has changed is that those epidemiology numbers and charts. That's it. That's the only thing that's new. And I'll do the same thing for today's. So for skin infections, which we finished, we're on respiratory. I will get there eventually today. All right, so we always start out like when we're dealing with the system of the body, what does the anatomy look like? What are the functions of it? And respiratory is kind of divided between upper respiratory and lower respiratory. And so for our upper respiratory, which comprises of all the components in your head and neck, and they're to function to regulate the temperature and water content of the air that you take in. Okay. In order for proper gas exchange to happen, it has to be at a certain temperature, right? We know molecular interactions happen best within certain temperature ranges, right? Chemical reactions are very much affected by temperature. Temperature's too low, too high, we get abnormalities. And then water, right? There has to be a certain level of moisture content to the air that you breathe. So your main breathing device is actually supposed to be your nose, right? Because in addition, it helps filter to the air that we breathe. But again, it's why it has that increased surface areas for the filtering, but also for warming the air and moisturizing the air that we breathe, which isn't necessarily a problem in Louisiana, right? We kind of have too much moisture sometimes. That's not a problem, but temperature can sometimes be important. So infections in this area tend to be uncomfortable, but not generally life-threatening, because the good news is if you can't breathe through your nose, you can breathe through your mouth. But there are other components that are connected to this part of the system that can be affected. So all the blue, dark blue shown here are cavities in your skull, referred to as your sinuses. And these can get filled up with fluid, these can get infected. We refer to this typically as being congested or stuffed up. And the reason why people sound differently when they're congested or stuffed up is because of the buildup of the fluid, the inflammation that's happening in these cavities. Your voice resonates through these cavities in your skull, and that's why your voice changes when you're congested, right? So that's why you sound the way that you do. Your ears are also, your inner ear is also connected to your nose via the eustachiary tube, which comes out in the back of your nose here, right? In the back of your nose, in the back of your throat. Your throat actually extends up behind the back of your nose. You have a tonsil back here that we've talked about, your adenoids, it's just one. The problem with its location is that if it swells, right, it can cause problems with this drainage of the nose and also the drainage of your ears, your inner ears. So you can get stuff blocked up in those areas because of that connection. Also, all your sinuses are linked to your nasal passages, okay? So here in this diagram, they're showing you the frontal sinus, which is the one here in your forehead, right? They're showing you the linkage here into your nose, into your nasal cavity. And typically how those get infected is spreading from the nasal cavity up into the sinuses or up into the ears. Your lower respiratory, of course, is where the gas exchange actually happens. So the point here is from your voice box down, your trachea, your bronchioles, the lungs themselves is all considered lower respiratory. And because of the vital necessary action of gas exchange that has to happen for life, these can be life-threatening when you have infections here, when you have fluid building up and you have limited gas exchange ability in your lungs. These are much more serious. When you see itis, they're just referring to inflammation, right? So in this case, they're talking about a particular location, the bronchi, right? Bronchitis is referring to as an inflammation. That's not telling you exactly what's causing it necessarily, right? It just means that the bronchioles are inflamed. Just same thing with pneumonia. Pneumonia is a general term for the buildup of fluid in the lungs. There's lots of things and a few different bacterial infections even that can lead to it, viral infections, that can cause some of these problems. So we're going to talk about some of these diseases and infections. So one of the things that helps protect our lower respiratory is one of the things that we talked about previously, one of our protection mechanisms, right? This is your mucociliary escalator, right? And this is that movement of the mucus up that's produced by your goblet cells, right? So they're producing the mucus. It happens in your nose, right? In your respiratory tract, these cells are ciliated. For your nose, it's moving stuff down so that you swallow it and it goes down your esophagus to your stomach where the stomach acids are going to destroy it. As far as your lower respiratory, it's actually beating up again so that hopefully you swallow it, goes down your esophagus and is destroyed by your stomach acids, right? That's the purpose of the system, is to move everything towards the outside of the body, right? Or in this case, to the outside that we consider inside, which is your stomach, right? It's actually considered an external environment. So what are the parts of your respiratory system that are normally free of bacteria, right? Would normally not have any normal bacteria associated with it. So your nasal cavity, your nasal pharynx, which as I said is that part of your throat behind your nose, your pharynx, which is your throat, what we commonly refer to our throat, are usually colonized with numerous bacteria, right? Other sites tend to be sterile. And there are numerous classes of organisms that are present, from aerobes to anaerobes, depending on the oxygen availability in the environment. Your conjunctiva, right, which surround your eye, right? What we commonly refer to as our eyelids that help protect our eyes, those usually have no bacteria. Any bacteria that lands on our eyes from the air, we're continually sweeping our eyes with our eyelids. Also, the tears that you're continually producing wash it into your nasolateral duct. That's the little tear ducts, what we commonly call your tear ducts and closest to your nose. They're continually washing this into your nose, right? And again, that normal path down to the stomach, eliminate anything. So your mastoid cells in your nose, your middle ear, your sinuses all connected to your nose, your trachea, your bronchi, your bronchioles, the alveoli themselves, normally without infection, right, under normal conditions, they are sterile. There's no microorganisms growing there, okay? It's only when we have infection that we have organisms growing in these areas. So what's the important opportunistic pathogen that commonly inhabits our nose? We've already been introduced to this one. It can cause some pretty serious skin infections. Staphylococcus aureus, right? Good old staph. Right. But we're specific in that Staphylococcus aureus. So as you can see, lots of normal bacteria that inhabit. We talked about staphylococci in our skin and the diphtheroids and the fungi in our respiratory tract. So basically in your nose and your throat, right? You could have any number of these organisms at any one time inhabiting your nose and throat. It's the ones that, are potentially pathogenic, like Staphylococcus aureus, that we, of course, worry about, and some of them that have the ability under certain circumstances to be pathogenic. Right, so potential, right, lots of potential pathogens. So we're going to first look at bacterial infections, and then we'll look at a couple viral infections, and again we're talking about associated with the upper respiratory. So we're going to compare strep throat to diphtheria, and you can see here in this diagram your uvula is part of your soft palate, right? This cute little punching bag here. This is not a tonsil, right? Some people confuse it with a tonsil. This is part of your soft palate. It's meant to help keep stuff from going up your nose. Some of us have experienced this, right? Sometimes when you drink certain sodas, you get that fizz up the nose, and that's because your throat, as you saw, is connected to your nose, right? So if stuff gets up past the soft palate, especially gassy stuff like a soda, you feel that fizz up behind in your nose, right? And it truly is there, right? Because it's done snuck past your soft palate, which is meant to keep stuff from moving upward. So this is a normal look down someone's throat. And normally, unless you're really looking, you wouldn't necessarily see their tonsils. This particular picture, you can see that the tonsils themselves on either side in the throat are very inflamed, right? And again, this mouth is open wide, right? And you can really see into the throat. So a good comparison between strep throat and diphtheria, they're obviously caused by two different pathogens. Strep throat is typically caused by Streptococcus pyogenes, and this is why it gets the nickname strep throat. It's actually an abbreviation of the genus name that causes this type of infection. Corynebacterium diphtheria is, of course, what causes diphtheria. And again, it's just part of the name of the organism, thank goodness, right, is actually the name of the disease. With strep throat, most of us have experienced this at one time or another in our lives. Extreme difficulty swallowing, right? Extremely painful. Where with diphtheria, the people tend to experience a much milder sore throat. With Streptococcus pyogenes, for strep throat, you can recover without treatment, although most people seek treatment, and one of the main reasons for that is that there are many complications that can potentially happen with this type of infection, right? So you're better off getting treated than, and most of us, it's such a painful sore throat, you don't want to wait for your immune system to take care of it. You want immediate help and relief. The scary thing with diphtheria is that it's a toxin producer, and when toxins are produced, it is deadly, right? And it produces a particular type of toxin called an AB toxin, which means it has two parts to it. The B component attaches or binds to our cells, and the A component is the toxic component of that toxin. And again, there are many mean things, lots of virulence factors for Streptococcus pyogenes. And then, as I said, the complications that we deal with. The bacteria for diphtheria is non-invasive, which means it doesn't really leave the throat, right? The bad news about this one is the toxin that it produces. Where strep, on the other hand, can leave the area of the throat and cause other infections. Those are the many different complications that we talk about. So this one can be invasive. Human only, they say. I've heard some people say that dogs can be carriers of this. I haven't done any extensive research into this. I don't think that it's probably the same thing. The good news with this is that it should be a limited population, although the human population is quite large. So that helps with control when we're only dealing with potentially humans. Humans are the main reservoir for diphtheria, but not the only one. So there are some animal carriers of this infection. There are anal carriers of Streptococcus pyogen, of strep throat. So there are people that can have this infection in their anus and be spreading it that way. Yeah, we won't talk about the details for that one. Cutaneous diphtheria. So where is that type of infection happening? In your skin, in the skin. So you can get an infection of diphtheria in the skin. We have no vaccine for strep throat. One of the main reasons for that is that it's an evil bug and it's continually changing what it looks like, right? So it's very difficult to develop an effective vaccine against that organism. Diphtheria, we don't have a vaccine against the bacteria, but we do have a vaccine against what? If it's a toxoid vaccine, what are we defending against? The toxin, right? Hence toxoid, right? So they're actually giving you the toxin, right, to mount an immune response to it. So that's how we're protected against that one. Do you guys remember what other, and we actually usually give both of these together in one shot. What other toxoid, what other infection did we talk about that's actually a toxoid? We talked about it under wound infections, especially under anaerobic conditions, as a spore former and it will germinate. It starts with a T. I can't give you any more clues, y'all. Tetanus. Tetanus and diphtheria, right, are usually given together in one shot, as well as pertussis, something we'll talk about in this topic as well. Treatment with antibiotics after culture. And so back in the day, they used to actually, culture it, grow it on blood agar plates, and I'll bring some of those in for us later this week. We got our shipment in, and I'll show you guys what blood agar plates look like, what this type of hemolysis that happens because of the exotoxins that staph can produce, Staphylococcus pyogenes. I won't bring that actual organism into this class, right? I'm going to bring plates using a different organism, non-pathogenic, that also causes that same phenomenon in the plates. So back in the day, they would take a swab of your throat, they would spread it onto a blood agar culture plate right in the doctor's office. The doctor would incubate it, and they would give you a call back and tell you to start the antibiotics if you were positive for this infection. Nowadays, anyone know what they can do? Rapid strep test, right? Where they'll swab your throat, and they're using very similar technology to pregnancy tests, where they're testing for the antigen, for the bacteria present in that swab, using specific antibodies and a color indicator. So it's a little snap kit, right? They add it in and the reaction starts and they get a result literally within minutes on whether you have this infection or not. What's the nice thing about early detection and proper diagnosis? What can we do earlier? Treat, right away, right? That day, you're not even waiting for us to culture it, the next day. We're not waiting 24 hours. We're literally within minutes know that you have this infection and we can begin treating. Because diphtheria is so serious and so life-threatening, they'll actually give you antibiotics if suspected before they even are able to culture it, right? For fear that the organism is growing, is going to produce toxins. And so what are they going to give you to help neutralize the toxins as well? They're going to give you anti-sera. And what is anti-sera? We talked about this with tetanus as well. What are they actually giving you when they give you anti-serum? What's going to protect you against a toxin? Your body makes it, but it takes time to make this product. But we can give it to you from someone else. Antibodies, right? Antibodies. That's what's an anti-serum is antibodies. And serum refers to the liquid phase of your blood after your blood is allowed to clot, right? Your antibodies are in that liquid phase of your blood. So that's why it's referred to as anti-sera. That's where it comes from. But it is antibodies against the specific toxin, right? And then your immune system will take care of eliminating them out the system. So in 2012, there was a probable case of non-fatal respiratory diphtheria, and they used a positive PCR test. What PCR is polymerase chain reaction, and this is to look at the DNA. So right down to the DNA level, they were able to determine the diphtheria toxin genes A and B. So they were present in this patient. And it was reported that an inaccurate immunization of the adult male and also the adult male with this condition had a history of AIDS, right? So his immune system was compromised on top of it all, right? So he had acquired immunodeficiency syndrome. So that was that one case in 2012. Other than that, we hadn't seen a case since 2003. Thanks to good widespread vaccination and mostly elimination of the pathogen from our environment. So with strep throat, Streptococcal Pharyngitis is another name for strep throat, which means that it's an inflammation of the throat, right? Itis. This is a picture of a blood agar plate, and here are the colonies growing. You can see intact red blood cells here by the red colorization to the plate, but then around the cells, they're producing an enzyme, an exotoxin, that literally destroys the red blood cells. And they're after the iron. Remember, our iron is very high concentration in our red blood cells. And that's probably one of the contributing factors of why that sore throat is so severe, is that these guys, as I said, have multiple virulence factors and create quite a bit of destruction to the cells in our body. So I'll bring in later this week actual plates so you can actually see this destruction of the red blood cells. They still do these types of tests nowadays. They just don't do it right in the doctor's office. They're going to usually swab you, put in a specialized tube, and it gets sent off to the lab for confirmation, in addition to doing the rapid strep test. It's a streptococcal, so if we were to look at it under the microscope, they're cocci, right, that form characteristic chains. It has a capsule, it has a special capsule, hyaluronic acid capsule. This particular type of capsule really interferes with our immune system with phagocytosis, stopping them from being tagged by C3b. And so notice they have many different virulence factors and components on their surface that interfere with our ability to recognize them. So there's that capsule, that specialized capsule that inhibits phagocytosis. M protein is the one that causes the breakdown of C3b, that opsonizing agent from complement, remember? So we're not able to detect it with complement. C5a, remember this is another complement protein. What does this cause? This is during the inflammation process, right? Of calling neutrophils to the area. These guys produce an enzyme that breaks down C5a. So even if complement gets activated, right, they're shutting down the alert system for our white blood cells, our neutrophils, to get to the area. They also have that FC binding ability for our IgG antibodies. So our IgG antibodies coat these bacteria in the wrong orientation. They're grabbing onto the portion that our body would hold on to. So really mean bugs. Some of them produce exotoxins that work as super antigens. So I think I had mentioned before when we talked about the different fever rashes, the different virus rashes, excuse me. Scarlet fever was on the list, but I pointed out that it was actually not from a virus. It's actually some strains, not all, some strains of Streptococcal produce this particular pathogen, and it'll cause scarlet fever, which is a characteristic rash associated with this toxin. They can even cause toxic shock, right, where it gets into the bloodstream and the person goes into shock. It also can cause a flesh-eating situation and wounds, right? So really nasty bacteria. Some of them also produce special toxins that lyse white blood cells and can lyse red blood cells. As I said, you can really see that on the blood agar plate. And then they can continue to deteriorate tissue, break down DNA, proteins, blood clots. They can chew right through blood clots. Really mean bacteria. Not anything you want to mess with. So immunization is really important for diphtheria, right? So that we don't get this toxin production. The really scary thing with this one, I want to see if they don't mention it here. Oh, here it is on the top. So sore throat, fever, fatigue, and malaise, but the toxins can destroy the cells of the throat. And so you get this membrane that forms on the tonsils or throat or in the nose, and it basically closes off the airways, right? And so the people aren't able to breathe, and that's usually how they die. The paralysis can also happen, heart and kidney failure can happen. So that membrane comes loose and obstructs the airways. So the other thing I mentioned is this AB toxin. So it's in two components. The B binds specifically to the surface of our cells by receptors that are present on our cells. And then it takes it in by endocytosis. And it's actually the A component that becomes toxic to those cells and kills those cells that have taken in this toxin. So effectiveness depends on early anti-serum treatment, right, that we properly diagnose and treat. If treatment is delayed because that toxin is so severe, as we said, it can be deadly. Antibiotics will be given to eliminate the bacteria and, of course, stop this transmission of the disease. But this has no effect on the toxin, right? If you already have toxin production, you need that anti-serum, right, to deal with those toxins. Right? Those are separate, those are released by the bacteria. So even in the presence of treatment, 1 in 10 patients sometimes die. Right? So it's pretty serious. It's one of those ones, again, that we want to make sure that we immunize against, right? To be able to neutralize the toxin. You produce antibodies that help you neutralize this toxin. Booster should be given every 10 years. As I said, the same as tetanus, probably one of the reasons why these are given together. D is for diphtheria. P is for pertussis, and it's actually AP now because it's a acellular vaccine against pertussis, which means that it's part of the bacteria they give you. Where with tetanus and diphtheria, it is both a toxoid, where they're giving you just the toxin. It gives you no protection against the bacteria itself. We're just really worried about those evil toxins. So erythromycin is a group of drugs, macrolide antibiotics, this particular class, slow the growth or sometimes kill sensitive bacteria by reducing the production of important proteins needed by the bacteria to survive. So what term is used for inhibition of growth? Anyone know? Bacterial static, right? So whenever you hear bacterial static, they're referring to interfering with growth, as opposed to bactericidal, which means what? To kill. Cytal means to kill. So this antibiotic is binding to something in the cell that's responsible for protein synthesis. What is it binding to? What's important in our cells for protein synthesis? What's its target? What makes proteins in our cells at the cellular level? Ribosomes. Ribosomes. So these drugs are literally binding to the ribosomes. That's how they interfere with the protein synthesis and can slow it down to the point where it could be lethal for that cell, or definitely inhibit their growth significantly. So that's what erythromycin does. Now you know. So other infections of the upper respiratory tract that are common is Streptococcus pneumoniae, although that one is more serious when it's in the lower respiratory because it typically, as the name implies, causes what? Pneumonia, right? Haemophilus influenzae, some people get confused because the influenzae part, this is actually a bacteria, but again, probably got its name due to the fact that it's similar symptoms to having the flu, what we call influenza. So Pinkeye, earaches, right? Inner ear infections, sinus infections. These can be caused by numerous different types of bacteria as well as several viruses. So these can be very difficult to treat. The additional complication is ear infections we're talking about internally, right? So it's not like the doctor could go take a swab and figure out what's causing your infection, right? You're not sticking a swab in your inner ear. That'd be kind of hard to get to. Same thing with sinus infections, right? It's not like you can see the infection. You can feel it, you know it's there, but to get at the root causes can be very difficult. Same is true even with Pinkeye, even though we can see this outwardly. Getting a reliable sample would be very difficult. No one wants their eyes probed, right, or swabbed. So with Haemophilus influenzae, this is a gram-negative bacteria. This is a very common offender, especially early in life. So they've developed a vaccine against a particular strain, the B strain, so that's why it's HIB vaccine, that's given to the very young. Although they've been giving this vaccine for a long period of time, we haven't seen any significant change in the epidemiology. In other words, we haven't seen a significant reduction in the number of earaches and ear infections that occur. And then that's probably because, like I said, so many other things are probably potentially the cause. So we may have significantly reduced the number of infections caused by this particular organism, but be able to test and know for sure, we don't have that ability, right? So that one's we hope so, right? Something is better than nothing. Where with Streptococcus pneumoniae, this is a gram-positive diplococci, sometimes commonly just referred to as pneumococcus. So it has many names in which it's referred to as. So pneumococcal conjugated vaccine, this particular vaccine is against 7 different strains of Streptococcus pyogens, right? That's the 7 in that. So, there are variations within species, and definitely a lot of variation when it comes to this particular organism. In this case, again, really hard to tell if we've made a significant reduction in ear and sinus infections that are potentially caused by this offender. But we definitely have a serious reduction in the number of pneumonia cases linked to this. So other ones that are top on the list that'll cause an infection of the ear, so otis media, referring to inner ear, and the sinuses are Mycoplasma pneumoniae, and this one has no cell membrane, cell wall, just a cell membrane, right? So I always remember mycoplasma, plasma referring to just having a cell membrane. So we talked about this one way back when we said about a particular genus that don't have a cell membrane. This one causes a milder form of pneumonia that we typically call walking pneumonia. But there's a complication in this. If it doesn't have a cell wall, can we give them penicillin? No, right? Because remember, penicillin targets the cell wall, peptidoglycan synthesis. So it's not effective against this particular organism. So it's really important sometimes in knowing what organisms you are dealing with, right, when treating infections. Streptococcus pyogens, remember I said, doesn't always necessarily stay in your throat. This one can cause serious ear and sinus infections. And then good old Staphylococcus aureus, right? Some people are carriers, others are experiencing a full-blown infection because of this organism. And then you have good old viruses. What's the bad news with viruses? How do we treat viruses? How do we treat viruses? Can I give my patient antibiotics? No, antibiotics are for bacteria, right? You don't. That's what he said. He's like, you tell them to go home and rest, drink lots of fluids, let it run its course. Your immune system, for the most part, has got to take care of it, right? So especially when people have been on multiple rounds of antibiotics, it might not be that you're not killing the bacteria. It may be that it's not a bacterial infection, and that's what a lot of people don't understand sometimes, right? You might be battling a viral infection. So most of us have seen, right, pink eye type infections. So you'll have the teary redness, the swelling of the eyelids, and it takes a particular strain of bacteria or virus to cause this type of infection, because they have to. Remember, the key to all infections is attachment. Especially here, we have very good defenses, right? We have the tears, which have things like lysozyme in them, right, and other antimicrobial substances. We have that continually washing ability of our eyelids and washing and moving the stuff out of that area. So you really only get these infections when you actually have a pathogen that can attach, right, and stay put and not be deteriorated by the tears, the antimicrobial action of the tears, or the mechanical action of that continuous movement. So depending, especially with a bacterial infection, you'll usually have that pus that forms. Highly contagious, right? Just touching and transferring it to someone else. Again, because these organisms have adapted to the point of really being good at attaching to the conjunctiva, to those eyelids, right? So they're so good at it, just a little bit will get you in big trouble. Sinuses, again, that pressure deals with the fact that you're talking about cavities in your skull, right? These have a defined size to them. There's no place for swelling to go, right? So the pressure really builds up in those cavities, right? You'll get tenderness, headache because of it's in your head, right? Severe tiredness because, again, you're dealing with an infection. The good news is they usually stay localized, right? It doesn't travel other places, but it can. And then the inner ear, much more common in children, and the reason for it is the anatomy of a child's ear canal. So for children, notice this is an adult ear. This tube is slightly angled downward, right, to help the movement of the fluid out of the ears into your nasal cavity through your eustachiary tubes. For young children, Theirs is more lateral, so less of a pitch to it, less likely for it to drain down. And then, as I said, for some, there's that added complication of the adenoids being there. And if the adenoids swell, they could block the opening of the eustachiary tube into the inner ear. So mild fever, although depending on the cause, right? Especially with bacterial. My son, when he was very young, he never complained. He would just spike this huge fever when he had ear infections. Some will vomit. And again, this usually has to do with the disturbance of the inner ear and its relationship with your balance, and so therefore it makes you nauseous. There have been some incidences too where, again, when you're dealing with young children and you don't really know that they're experiencing pain, they don't really understand it. The eardrum itself can sometimes rupture, right? And this can be very serious type situation. For young children, depending on the reason of the cause, sometimes they'll insert these little microscopic, and I'm not kidding you, they're microscopic tubes to help in the drainage of those ears as the children are growing. So for my son, it ended up being linking to allergy. So once we got him on allergy meds, and as he continued to grow and his head expanded, and those pitched down, one tube fell out on its own. The other tube had to unfortunately be surgically removed after, I think it was like 3 years. But he hasn't had any ear infections since the surgery, because in addition, they removed about 80% of his adenoid in the back of his nose to help with that swelling up and blocking of the eustachiary tubes. And then he's on allergy medicine like me. So that's one of the major contributors nowadays to difficulties, nasal problems, is allergy, right? One of the things that we talked about. But also, unfortunately, young children have the whole anatomy problem against them, right? Where they don't quite have that pitch to their eustachiary tubes to help in the draining. So it can be many different factors that factor in. So, where do these infections come from? Very few details are known about the pathogenicity of bacterial conjunctivitis. Most likely it's airborne. Respiratory droplets is actually how we get in contact with it. And as I said, highly contagious. And they're resistant to lysozyme, right? So one of the actions of our tears meant to destroy the peptidoglycan component of gram-positive bacteria doesn't work. With sinus infections, as I said, it's usually a spread from your nose, from your nasal pharynx upward, right, into the sinuses. And then it can even spread into the ears from there as well, right? And that's mainly where most of the infections of the inner ear is coming from. And so it would make sense, too, that you'll sometimes have conjunctivitis and then follow it up with an ear infection, because you had an infection of your eyes, right? It's leaking into your nose, which then can get to your inner ear, right? It's all linked together, right? Infections move to the middle ear, and they can damage sometimes those ciliated cells that are responsible for moving stuff out of that area as well, right? And so that's why they're able to persist in those areas. The eardrum often bursts and then can give immediate relief to the pain. Of course, there's some place for the pressure and the fluid to then go. Of course, you don't particularly want that to happen. You hope to get treatment, right, before that happens. I had a really bad buildup one time after flying in my ears, so much so that, you feel like you're underwater all the time and you have that pain. And I went to a doctor and he's like, oh, well, we could, poke in a hole in your eardrum right now and you'd be all set. And I'm like, yeah, no, I think I'm good. What's the other option? He's like, well, we could try steroids. I'm like, okay. One day later, one ear popped. Next day later, the other ear popped, right? It was a buildup of inflammation, right? And the additional pressure of flying really compacted things into that area and it wasn't getting out, right? So I'm sure most of us have experienced that type of pressure at one time or another, right? Never fly when you're sick, right? If you can avoid it, or take lots of decongestants to clear out all that area before you fly. All right, so we'll pick up from here next time. And as I said, I updated the epidemiology on here, so if any of you guys want the updated graphs, I'm post that on Blackboard.